Okay, Colin Coxall, welcome to the show.
Thanks, Sam. It's a pleasure being with you today on your show. Congratulations at getting the show up and running. It's much needed, I think. Well done.
Oh, thank you. Now, Colin, you're a CBT practitioner. Now, I'm not sure if you're aware of this, but a few years ago at Club 360, we actually ran a CBT program where CBT stood for core, butts, and thighs. So it was
Mm.
basically a class with a lot of squats, lunges, and deadlifts and the like. I'm assuming that the CBT that you practice is somewhat different.
Yeah, well, I quite like the idea of that abbreviation. I mean, CBT has lots of different abbreviations if you Google it, but for me, it's cognitive behavioural therapy, and I think the difference between that and what you described is, or maybe a similarity, is that it's open-minded.
Mm.
So cognitive behavioural therapy. I mean, it's based on changing our emotions. So really, the goal is about changing, our distress, our emotions, and the way we do that is that we use cognitions, the way we think about things. So thoughts, images, memories. I mean, the idea has been around since Greek times. It's not really a new idea.
Mm.
Um, and the B is the behaviors, so changing what we do. And then we kind of mix it all up by using the therapy. So what, I mean, there's lots of ideas and strategies and techniques, but really the devil is in the detail about how you mix all of those up and how you formulate those ideas and how you adapt them to, the problem and, the individual. And when I say, it's open-minded, in what I do, cognitive behavioral therapy, everything is on the table. It's open, everything is overt. Often I might not get it right, but we usually get there. We work as a team, and we always have a focus on life after therapy. I think that's the main difference in
Mm.
what I do. We don't just kind of fix the problem and walk away. Really, the focus is on, life after therapy. My goal really is to help people to become their own therapists, and that's why cognitive behavioral therapy is often shorter than other therapies. It's not that it's better; it's just that is our focus.
Yeah.
I always like to have an idea of um, not necessarily how many sessions. It's hard to say, but I think after we've done an assessment, you can get a good idea of how many sessions it might take to alleviate a particular problem. Um, but I think more importantly, it's about thinking about endings right at the beginning, and that's what we do. If I put myself out of a job, I've usually done a good job, unless
Mm.
somebody doesn't like what I do and walks away in the middle of therapy, which does happen sometimes. I don't always get it right. That's
Yeah.
that's absolutely fine.
Yeah, I
Um,
think, I
mm,
mean, as a physiotherapist, you can definitely relate. That's what we try to achieve with our treatments is to get the patient to become their own therapist, give them the tools to manage their condition and give them autonomy in managing the condition. So, yeah, I think I can definitely see a lot of parallels there. Uh,
yeah.
we'll go, I guess, into a little bit more detail about the actual practice, but perhaps for those who aren't familiar with you, what's your story? How did you how did you get into this field, and what brought you to Japan?
Yeah. So I have family interests in Japan. So Japan and the UK are kind of in my blood, should we say? And I spent 5 years in Japan. When was it now? It would 2005 to 2010. I was actually working at a university. I was teaching social work there because my background is actually social work, and I was doing various bits and pieces, and I was volunteering here as well. And my family and I, we went back to the UK, and we I really got involved in cognitive behavioral therapy because my initial degree was in economics, believe it or not.
Right.
And there is quite a nice connection between economics and cognitive behavioral therapy, because there was a big movement in England from the London School of Economics, which was really about well-being economics. And really this idea was developed by Richard Layard and David Clark, who was a prominent cognitive behavioral therapist, to develop the idea of well-being back in the UK. And I just really got hooked on that idea. So I took my my social work, my economics, formulated it, and I was very fortunate because I was one of the people that got trained as a cognitive behavioral therapist back in England at the University of London. And so that was a year's full-time training, and then a year kind of as an apprentice before I became a cognitive behavioral therapist. So that's really my story. So it started off in economics, went into social work, to teaching it, back to the UK, trained to be a CBT therapist, and then I became an academic. And I began actually teaching cognitive behavioral therapy, and I set up a program back in the UK, helped set up a program for young people. There was a program developed to take CBT and evidence-based practices into schools. So I was very lucky to help set that up, and I did that, finished, and then it was time to come back to Japan, because there were some wonderful things happening, the Rugby World Cup and the Olympics, and we thought it would be a nice time for our family to move back, and it has been for many different reasons, but also tinged with sadness, of course, about what's been happening in certainly back in the UK and other parts of the world with COVID.
Yeah. Yeah. And you're currently practicing out of the Tokyo Medical and Surgical Clinic, is that correct? Or you're affiliated there, but doing your clinical practice remotely online?
That's right.
With online sessions, right?
Yeah, remotely at the moment. Yeah, that's right. We'll be partly because with the COVID restrictions, one of the issues is spending a long time in very close proximity with somebody, wearing a mask as well. We're mandated to wear masks, and it's quite difficult to do therapy wearing a mask. And also, there's no reason why we can't do it remotely at the moment. It seems to work pretty well. Yeah. But hopefully we'll go back to working face to face in a not too distant future. Yeah. But I think we spoke about this before. I think it's going to be more of a hybrid. I think the inhibitions about working online really have been broken. And I'd like to do more of this kind of stuff, even kind of text-based therapy as well as kind of video therapy. I think there is an issue which is really important in therapy about information retention. And actually, I think using technology can be really helpful because you can kind of record things. You can record the sessions and keep the information.
Yeah,
of course.
Yeah. But interesting. Yeah. I guess just going back to CBT as a model and as a type of mental health intervention, for those listeners who may have undergone other types of mental health interventions, counselling, things like that, how might your approach differ? And what are some of the things that may differ? What are some of the similarities? And
I mean, as I said earlier, I don't think cognitive behavioral therapy is necessarily better than other approaches. It just, it's another one. It just brings something else to the table, and it certainly has its strengths in terms of the core issues that it deals with, which really are anxiety and depression. It's got a good track record in other areas such as eating disorders, developing resilience and trauma as well. But I think anxiety and depression really are at the core. And our question here always is, why are you having these difficulties, and why aren't they going away? And one of the things that cognitive behavioral therapy is particularly interested in is what we're doing that's kind of maintaining the problem, that might be keeping the problem going. So, for example, in depression, typically in loss, the theme, that the loss being the theme, people might withdraw from the world. They might stop doing things. Might not return calls, and then wonder why nobody's calling them. And so there are kind of unintended consequences often to what we're doing, such as avoidance. It just makes us more withdrawn and can make us more depressed, and it's a bit kind of circular. So it's about understanding those cycles and perhaps breaking those patterns and looking at an alternative view of doing things, expanding our bandwidth, for example, of what alternatives there might be. Does that make sense?
Yeah, it does. Yeah. I was wondering if you could sort of provide like perhaps a bit more of a case study or practical example of some sort of specific techniques that you might use with an individual. Let's say someone is suffering from anxiety. What are some of the things? How would you? What sort of information would you be gleaning from the assessment? And what are some of the techniques that you may use to?
Okay. So cognitive behavioral therapy. Let me just go back to say about cognitive behavioral therapy is really it should really be called cognitive behavioral therapies, because actually it's a bit of an umbrella term for different approaches. So, for example, newer approaches might be things like mindfulness and EMDR, which has been around a while. Actually, things like acceptance.
Sorry, Colin. What's EMDR?
Yes. Sorry. Eye movement desensitization reprocessing. It's how can you describe it? It's the movement of the eyes. I mean, it's similar to rapid eye movement when you dream and process emotions. It's the same kind of process. Other things like acceptance and commitment therapy, which is used in, for example, in pain work, mindfulness as well, which the strength of mindfulness is really in relapse prevention for recurrent depression. Really, and there seems to be an idea that mindfulness is a fix for everything. Actually, it's not. The evidence base is that it's for recurrent depression. Actually, although it might be helpful for people. But it's certainly not a fix-all. In fact, in some situations, such as in rumination and in worry, it can potentially make things worse.
Really?
Potentially. So the devil is always in the detail, really.
Yeah,
so that's my roundabout way to say that my approach is very much formulation-driven. It comes from the work of Aaron Beck, so you call it Beckian formulation-driven cognitive behavioural therapy. That's really where all the evidence, has been for the effectiveness of CBT, and really it starts with the idea of assessment, finding out what the problem is, and as I say, then it moves into that formulation, understanding the problem, putting it together and understanding what is keeping the problem going, what's driving the problem, and then we move into the treatment phase. So then the strategies and the techniques, very specific to the individual, and one of the things that we're very aware of in cognitive behavioral therapy is that one of the things we do slightly different is that we do look at things like diagnoses. I mean, in terms of anxiety disorders, there are very specific thoughts that link into specific anxiety disorders. For example, in panic, it will be catastrophe of something very bad happening, like thinking you can have a heart attack, losing control, going crazy, going to faint. Usually something catastrophic immediately there and then is going to happen. In worry, generalized anxiety disorder, which is rather common, which people tend to miss, it is often triggered by uncertainty. It's usually that what if, and there are kind of worries that come with that So uncertainty, what if, worry, anxiety, and it can flip into being uncontrollable, and it can be exhausting. Sam, you probably see people that worry a lot because you get a lot of physiological manifestations,
Sure.
muscle pain and tension, and it can undermine people's confidence as well. Other things, body disturbance, social anxiety is very common, and it is, unless you look for it, you won't find it. It's often about, kind of judgment from other people, other people judging us negatively. There are certain triggers. People might think, I'm not in, that I'm just blabbering on and I'm not interesting, which is true, but I don't particularly. I'll bore you into submission, Sam. It's fine. And other things like obsessive compulsive disorder, for example, which is about how, and that could really be about anything. You can obsess about anything, and then you do things to manage those obsessions to reduce your anxiety, and it can create a really unhelpful loop. Typically things around contamination or interesting. I was discussing about perinatal OCD as well, which is it can be about anything really, OCD. And something like health anxiety. I mean, at the heart of all of these, you might have something called an anxiety equation. All right, so I always think about the anxiety equation. So, for example, in health anxiety, I might think that I have a certain illness. Okay, so I will perceive the likelihood of having, some terrible illness as, likely, let's say, and then I will perceive how awful that will be, because anxiety tends to be about a future situation. So I'll, think, well, I'm going to be a burden to people, and it's going to be terrible. And then, I'll think I'm not going to be able to cope with it. So coping is another part of the equation. So I'm not going to be able to cope with it. I'll fall apart. And then, I might perceive that other people aren't going to be able to help me. People aren't going to know, what's wrong with me. It's going to be terrible. Nobody's going to find out. So I always have this idea of how, the anxiety equation, how probable people think something is that will happen, usually catastrophic, how awful it will be, how they perceive they're going to cope with it, and how other people are going to help, you see. And if people's perception of how likely it is, how awful it will be, and how they're not going to cope, and how others aren't going to help them, if that's high, then it's going to create this it's going to create the distress, and it's going to create a problem. All right, whether that's in health or other areas. So we always look at probability. I mean, for example, in worrying about things, well, uncertainty is just a part of life. Actually things turn out pretty well, and usually we can cope with them, and they're not as bad as we think they're going to be. Everybody gets ill at some point in their life. Most people cope with that, and to some degree, and people generally are resilient, and other people generally can help. So there's always another kind of perspective, another narrative to do so. I don't know if that makes, is that helpful? Is that
absolutely? Yeah, no, that's really helpful. That in itself is a very practical example of how you might address one's issues. So that's great. You touched on before technology, and I mean, have you yourself seen the use of technology increase in mental health treatment in the last, I guess, half decade? I don't know. For us, the way that we deliver our interventions, the way that we deliver exercise programs and things like that, that's all technology based. We have apps where people log in, they see their exercise programs, they can track their adherence to those. Have you seen that sort of practice emerge in recent years? And is it something that you employ yourself?
Yeah, very much. I mean, at the heart of what I do is really, meeting with people and kind of, form. I mean, it's more the method by how we do it that's for me has changed. So, for example, through Zoom, typically, or more phone work, or even text-based therapy can be helpful as well. And I was mentioning about information retention as well. Other forms of therapy can be quite helpful because you can, I think it said you can even record the sessions and you have access to the information. That's always a problem in therapy, you see, information retention. And there's only so many times that you can kind of, repeat yourself. You've got to kind of, at some point learn, what you want to change. I mean, I know in
Mm.
some therapies, they kind of, it really is their MO, and just kind of waiting until somebody gets it. Well, I think you can get there quicker,
Sure.
by perhaps use of technology, and things like apps can be incredibly helpful. I think places like Netflix, I think they've got some really excellent programs at the moment. Explain Your
Okay.
Mind and the Headspace programs, I think they're excellent. I think some of the information out there is much better than it was. Apps, there's an AI app which really annoyed me called Wobot, and I was saying you can't have an AI CBT therapist. They'd be rubbish. They can't do it as well as me. So I tried it, and it really annoyed me because it was pretty good. The
Wow. Okay.
so there are some really good apps. There's some really good stuff out there. I say the Headspace apps, and what else would there be? Think Ninja for young people. It's
Okay.
there's a lot of really really good stuff out there. But I always see the technology not as a replacement, but an adjunct
Yeah,
to
as a supplement. Yeah. Yeah.
to supplement to what we do. Yeah.
In the last year, with what's been going on with COVID, have you seen different presentations in people's mental health problems? Have you seen more sort of COVID-related worry? Have you seen even the opposite, where people have sort of changed their mindset in terms of decreased worry because in comparison to some of the other things that are going on in the world, they actually have less to worry about. They still have their house, they still have their health, still have their employment. Maybe it just puts everything else in perspective. Have you seen any sort of trends in relation to COVID?
Yeah, I think all of the above. I've definitely seen trends. So, for example, um, people who are socially anxious, they're not it's functional at the moment because people don't have to go out and face their fears, and I do wonder whether what's going to happen, when COVID finishes and we're back into our usual social situations, whether it's a temporary thing or whether it's going to be a permanent thing. People don't get anxious about those sort of things anymore. OCD, for example, contamination based OCD, I mean,
Mm,
when functionally we're all now washing our hands and doing stuff that we wouldn't have done like 18 months ago. You'd have sort of been thinking, well, that's kind of OCD type behavior, it's totally unnecessary, but really now it is completely necessary. It's always functional.
yeah,
It's
yeah,
always about applying it to the context, isn't it, really? I always say the rules we have, they're all helpful, but they're all unhelpful. It just depends on the context. So then the question is going to be, when COVID recedes and we go back to doing the bunny ears normal, whatever that will look like in due course, whether you know people will, I think most people will revert back to, will be able to adapt, but I do wonder whether people with some problems like particularly OCD and maybe contamination based OCD or worry even, whether it will remain a problem and even possibly enhanced as a problem. I think people have been isolated. Um, I think depression has been an issue. I think there's a lot of people who are very lonely at the moment.
mm,
Um, I think there is some people have spoken about trauma, for example. I mean, I do worry about our healthcare workers about them being treated very well at the moment. They need to be treated well and prized, because I
Sure.
think they're going through a tough time at the moment. In terms of PTSD, and I'm not sure so much about PTSD, but because this COVID thing is a kind of, it's almost like an act of God, isn't it? It's not a deliberate act, but when you see, if you're not being treated well, and it's not necessarily PTSD, but you're going to have a lot of anger and stuff around from if you don't treat people well. All right, so this is more of a wider thing. It's just a little bit of a you see the trends that happen certainly in my country, for example, that it's very important to treat people well at this time and really to look after each other. So I think some things are being exacerbated. I think loneliness, and I think some things are being normalized, like some of the OCD behaviors, and I think some things are being the avoidance of like social situations is really kind of helping people's distress at the moment. The thing is, what's going to happen afterwards, really. I think there's some burnout, some technology burnout. I know maybe some of the teachers, for example, they're doing a lot of stuff online. I think it's difficult because their work doesn't change. It's doing all, having to adapt online and doing all the marketing, and so I think for some industries, for some people, I think the stress has increased. It'll be interesting to see how people readapt when COVID recedes, which hopefully will do soon.
Yeah, absolutely. It'll be interesting to see
how
the world readapts.
Have you any thoughts on that, Sam? What are your thoughts about where we're going on that? What patterns have you seen?
Well, I guess from from what we see in terms of mental health, as physiotherapists and trainers, we have a strong connection with our patients, and we've sort of noticed similar patterns to you. From the actual physical side, we've definitely noticed patterns. People starting different activities. So I had a person in yesterday who used to swim a lot. Their pool was closed due to COVID. They started running. They developed a knee injury. People are stuck at home. They're doing exercise programs that they've found online, and it's really just things that they're not used to, that they do too much too quickly. And really, most musculoskeletal injury is a result of too much of a load applied too quickly. Those are sort of the main patterns that we've seen in relation to COVID, is just a change in activity, causing different stresses to the body, and I guess a change in working environments as well.
Yes.
A change in postures, people going from working at a desktop to working on the dining table on a laptop, and not that that's an inferior posture, it's just different to what the body's used to, and that will because of that induce a different types of stress. And people, almost counterintuitively, people think that because they're working at home, they're going to have a little bit more time, but they have other pressures of working at home, having to balance that with being around the family more, and also not really having an out. There's for a lot of people, once they leave the office, they can sort of close off from work. That's not always the case, of course, but I know a lot of people have found that being at home, it's almost because that's their new workplace, they're always at work. And I think
they're working harder. I've noticed that. Yeah.
And like you said, I think a lot of industries will go to a hybrid model. I don't think we're going to go back to where we were. This is like you said, in bunny ears, the new normal, and there'll be a lot of changes that come out from COVID. And I think a lot of these changes will be positive, but there does need to be a bit of an adjustment in the way that we do things and the way that we think about things.
Yeah. I think one of the stresses as well has been certainly people working at home. Has been stress on relationships as well. So for example, if one partner kind of focuses more time at home, suddenly the other partner is in their workplace. Do you know what I mean? And that can kind of increase stress. It's like, I'm working at home, I'm doing all my work in. Well, yes, you are, but you're also in kind of somebody else's workplace as well. Do you know what I mean? And I think that can also create some stresses, because it's about adapting to that as well within relationships too. And maybe that's a little bit of a pattern that I've seen. Some relationships have just had it just takes time to adjust to it, and it's just another it's another stressor really.
Great. Okay. And it's probably worth maybe following up once COVID does settle, and reflecting on some of the trends that you've seen and how those have changed, and and going back and sort of reviewing some of the things we've talked about. It'll be interesting to see where the world is, I guess, in a mental health space once we come out of this.
I think people are much more resilient than we often, it's a bit of a generalization, than we often give them credit for. Human beings, we're born to be resilient, and usually we get things pretty quickly. And I think, in terms of some of the self-help stuff, I think cognitive behavioral therapy can really bring something to the table in terms of helping people regain that balance in their life. I sometimes think that cognitive behavioral therapy should be renamed compromise and balance therapy. Actually, I think that's a big theme of CBT, and it doesn't necessarily have to be coming to see somebody like me. There are some very good, we've spoken about apps and books and resources around that can just give you some strategies and some tips. Okay. And also people like you, Sam. You're interested in things like cognitive behavioral therapy. So some of the strategies and tips, you have them. You can use those as well. You don't always have to come and see somebody like me. If that makes sense. You can if you want. Obviously, I do need to pay my rent, but you don't have to. It's CBT is a gift that keeps on giving, really. And it doesn't have to be sort of that hour one-to-one. It can be much more sort of, the intensity can be much kind of lower in a more kind of self-helpy kind of way. And I'm happy to, I want to try and create some kind of some resource library, maybe a little self-help library here in Tokyo, or I don't know, app library, or whatever it is that might be helpful.
Well, I think we mentioned off by air that I'd like to have you back on in the future and talk about some more specific mental health conditions, and go into a little bit more detail on that, and perhaps in that space we could go through some different apps, and we could maybe try to formulate some sort of library of resources for people. So if there's any listeners that have specific topics that you would like Colin to speak about, then please get in contact via our socials. You can DM me there, and we will get Colin back on and go over some more specific topics then. So might be a good place to wrap it up. Thanks very much for coming on and sharing your time with us. If people do want to get in contact with you, or indeed do want to book an appointment with you, how would they go about that?
Well, then the first thing is to find out a little bit more about what I do, about me. And you can do that by going on my website, which is cbt.tokyo.
Okay, terrific. And I'll put that in the links in the show notes.
Or you can contact the clinic, the Tokyo Medical and Surgical Clinic.
Great. Okay, and I'll put their links in the notes as well. Okay, so thank you very much for coming on, Colin. And as I said, we'll get you back in the near future, and then have another chat.
Thanks, I appreciate it. Thanks very much, Sam. Take care.
Right. Cheers. You too.